So in the next couple of minutes, I'm going to talk about two things with cones. And I think there are two reasons to use cones in revision total knee. One is for long-term fixation, and second is for treatment of bone loss. And they often go together, but they can be independent as well. So if we look at the Anderson Orthopedic Research Institute classification, this is the most widely used classification for bone loss. Type 1 is basically you take the implants off and you look at the bone and you're like, hey, that looks pretty good. Type 2, you have damaged metaphyseal bone on one side or both sides. And type 3 are the massive bone loss patients that you see. Type 3s are the ones that we really worry about. So if we look at fixation in revision total knee replacement, and Amar talked about this a little bit with that radiolucent line where the cement was, really over the last decade or so, we've started talking about zonal fixation in revision total knee replacement. And I think this is one of the key points of this talk. When you're doing a revision total knee replacement, there are three zones. There's the epiphysis, the metaphysis, and the diaphysis. Now, usually if you're doing a revision total knee replacement, the epiphysis is poor, right? It's either you're missing bone, it's sclerotic bone, you're not going to get good cement interdigitation. You want good fixation in two of these three zones. If you get good fixation in two of these three zones, you're going to have a good long-term outcome. So if you can get good metaphyseal fixation and good diaphyseal fixation, that epiphyseal fixation doesn't really matter very much. So zone 1, the epiphysis, zone 3, the diaphysis. Those we're not really talking about in this talk. We're spending most of the time talking about the metaphyseal zone. So over the past 20 years, but really more over the last decade, we've improved our metaphyseal fixation with both cones and sleeves. The next talk we'll be talking about sleeves. I'm just going to talk about cones. So cones in revision total knee arthroplasty, they've been around for almost 20 years now. They're porous metals. The initial ones were trabecular metal cones, and they transformed the way we do revision total knee replacement, but they were hard to use. You had to use a burr, you had to burr, you take it out, you put it back in. They were hard to put in. So the advances in cones over the last few years have actually been how we put them in. So in terms of cones versus sleeves, I would argue that cones are easy to use. They're versatile because we can use them for fixation or bone loss. They're flexible, meaning you can mix and match. You can put whichever cone in you want with whichever implant in. When you put a sleeve, it has to match the implant. And the long-term results, and when I say long-term results, I mean more than 10 years now, have been highly favorable for revision total knee with cones. So there are a couple of different techniques, but most of them today are pretty simple. I'm going to show you two separate techniques. This one is a ream and broach. So you ream first, and then you broach, and then you put your cone in. I think this is good for fixation. So if you've got cancellous bone, you can broach. If you've got sclerotic bone, you probably don't want to broach. You'll crack the tibia or the femur if you're broaching into sclerotic bone. So the broach type cones are good for fixation if you've got cancellous bone. Same thing on the femoral side, ream, then broach, then put your implant in. If you have sclerotic bone, so you take your implants out and you're looking in there and it's not fresh, clean bone, then you should probably use a ream-only type cone so that you don't crack the cortex, you don't crack the bone. And there are different types of cones available. So there are these central cones, right, that can be used to help really just with fixation. And then there are these oblong cones that can be used for greater bone loss. So there are all sorts of different shapes and sizes of cones that we can use today, both on the tibia and on the femur. Femur, same thing, central ream, then peripheral ream, and then you put your cones in. There are now even some metadiaphyseal cones, so for the really massive bone loss where you're thinking you might need to use a distal femoral replacement, sometimes you can rebuild that distal femur with these cones that actually get fixation right up into the metadiaphyseal region here, and then you can seat your distal femoral implant right on these flanges down at the bottom. So cone technology continues to improve, and we're continuing to get better and better results. So any cone can be used with any implant as long as the housing of the implant can fit inside that cone. So you just need to make sure the sizes match. So reliability, good mid to long-term data showing aseptic loosening rates of 1% or less. So the durability of these has really been excellent. One technique thing that matters is sometimes when you put these cones in and you cement around them, you can actually have cement that comes up underneath them and gets between the cone and the bone. You got to make sure that you don't do that, otherwise you're not going to get ingrowth of those cones. You're going to get just a cemented stem. So just one quick case here to show everybody. This was type 3 bone loss, massive bone loss on the tibia and the femur. You can see close up, big holes. You can fill those holes with these cones, different shapes and sizes, and then ultimately revise that implant and have good long-term outcomes. So in conclusion, 2025, cone fixation allows for safe, simple, and durable fixation. Don't stress about zone 1. Don't spend all this time trying to make sure that that epiphysis is good. If you can get good zone 2 and zone 3 fixation, you're in good shape. Thanks very much.